Okay, I'd like to invite everyone to take a seat. I know we're all still coming back from morning tea and start wrapping up our conversations because we need to kick off for the next session. We've got a number of really exciting presentations. So I might just start, while everyone's sitting down, I might take the chance to tell you a little bit about our first speaker. So we'll be hearing from Associate Professor Kim Delbert. She's the Principal Research Scientist at Neuroscience Research Australia and an Associate Professor at the University of New South Wales. She's supported by an NHMRC Career Development Fellowships since 2012. And her research has contributed to the understanding of physical, psychological and cognitive factors causing falls. Her multidisciplinary approach incorporates elements from physiotherapy, psychology, brain imaging and software engineering towards preventing falls and promoting healthy ageing. Okay, so the title of Kim's presentation today is, while everyone's getting into their seats, keep in mind there's a few seats at the front if you're still walking in. So Kim is going to be presenting today a really exciting opportunity to hear the results of the Standing Tall RCT, which is using mobile technology to deliver an unsupervised balance exercise program. So join me in welcoming Kim.
Thank you very much for the lovely introduction. So today I will share the results of the RCT. We're still finalising the analysis, but it will give you an indication of where we're thinking of what's going on. Click on it. Yep. All right. Correct. While people are coming in, I won't preach too much here because we all know this, but so just to show what this talk is about and where we started from. So exercise is the single most effective strategy to prevent falls, and that's really what we try to do, is to find a better way to give exercise. And what we tried to do was really that we wanted to increase uptake, so that was the key part of what we aim to do with our Standing Tall program. We know that exercise works, but we also know that older people do not take it up. And they also often don't know how important it is to exercise and what it means to prevent falls doing exercise. And then if we do get to people to take it up, then there is another issue that's coming in, and that's people to comply with the 2 hours a week of moderately to highly challenging exercise, attending group sessions and completing the long-term group sessions. So we want something that is challenging but also feasible, tailored to the person, to their circumstances and their abilities. So that's really what we try to do. And how we tried to do that was to use novel methods. So we use technology. And we are in the e-health space, but especially in the m-health. So we are using mobile technology to deliver our exercise program. And we aim to have an active engagement through self-management, optimizing our delivery and the dissemination of our program using technology, and maximizing adherence by monitoring what people are doing and also giving them the opportunity to monitor themselves. And also, hopefully, we'll figure that out soon with our cost effectiveness analysis, but containing the costs. So what were the aims? So we designed a program which was called Standing Tall that was delivered on an iPad. So it was a tablet-delivered technology. And we gave this to people for 24 months. So the results that I will present today is a 12-month follow-up because the study is not quite finished yet for the 24 months. I will present to you our effects on falls, as well as a few fall risk factors, comparing to a health promotion education program. And in the next year, we will also have a look at the effectiveness over 2 years. We will try to predict adherence over a longer period of time and look at the cost effectiveness. who were the people in the trial? So we had over 500 people, 510 people in the trial. They were all 70 and over, living in the community, independent in their activities of daily life, and essentially everyone was included as long as they were able to walk household distances without the need for a walking aid. So they could use a walking aid, but as long as they were able to do that. People who were excluded were people with an unstable medical condition or a progressive neurological disease, which would make it just difficult to analyze the results. So our sample size that we aimed for, so we aimed for 500 people, and the reason how we calculated that was we aimed for a 33% effect and a 20% dropout rate. So that is how we got to that number and what we needed to get a significant effect. So we ended up with 510 people, actually. So this is the flow chart of how people went through the study. So they started off with a baseline assessment, after which we did a concealed randomization, and then we divided it into two groups, or an intervention and education control group. We had a home visit at the beginning and then again at 4 weeks. So the first home visit was to do an installation in the intervention group, and then the 4-week home visit was a follow-up, just to make sure that people were doing the exercise program safely. At 6 months, we did a remote assessment using questionnaires, and we also did in a few people, in 200 people, we also did an assessment at Neura again. So we are following people up for 24 months, which is still ongoing. This is the health promotion education program. So we gave this to everyone, control group and intervention group, and it was a weekly program. So every week people receive a new fact sheet, which is on health-related information related, which is relevant to all the people. And we, over 2 years, you can imagine that we had quite a lot of fact sheets. So we ended up adding some recipes in there as well, which were actually really well received. And this is also delivered through the iPad, just to make sure that people stayed engaged with the tablet. And this is also for the control group, because we collected our false data through the tablet. The control group also received an iPad. So this is our standing tall balance exercise program. So this is generally the look of it. So we made sure, so it was a convenient program that people could do in their own home. We asked to do it every, for 2 hours per week. It was tailored to their ability, and I'll give a little bit more information on how we did that in a minute. It progressed at their own pace, so no matter how quickly or how slowly they progressed, it was always at their own pace, and there was no one there. So it was really just the tablet and the person for a year and 2 years eventually. We had 2,000 exercises in our program, and we gave feedback throughout the program as well on their progress. How we got to 2,000 exercises, you wonder probably, how many balance exercises can you come up with? So we had this prop, which was a mat. It's not a smart mat. It doesn't have technology in it. It's essentially just a colored rug that you see here, which is showing just a dartboard stepping pattern that people could do. We also had a foam cushion and a step box, and that's essentially how we came up with all these different exercises. So how does it work? So this is the flow of an exercise program, or an exercise session, I should say. So we have standing balance exercises, which is leaning on the floor, just leaning left to right, standing on one leg, those type of exercises. Every exercise gets repeated 3 times, and then at that point they have to say how easy or how hard it was. based on their response to their balance ability during the exercise session will progress next time to a harder or an easier exercise. We also had box exercises and those stepping exercises on the mat. And that's essentially how we came up with all these different number of exercises, and every exercise session was generated at the time for the amount of minutes that people decided they wanted to do the session for. You can see it might be a bit small, but on the left-hand side, they could choose a session taking from 10 minutes up to half an hour every time. Our methods, so we had just over 200 people whom we did physical assessments with repeatedly, so at 6 months and 12 months as well. The others, we only did questionnaire and monitoring data. So for the physical tests, we had the physiological profile assessment, balance assessments, mobility, walking, reactive stepping, and also cognitive performance. For questionnaires, we asked about depression, concern about falling, general well-being, quality of life, and also self-reported physical activity. And for the monitoring, so we did this in everyone. We asked obviously about falls, and we did that through the iPad for everyone. We also asked about health services and adverse events. But what we also did, and that's something that we still need to look at, we did daily activity monitoring in everyone as well at all the different time points. So that will be very exciting to see those results. I won't bore you too much with the statistical analysis. So we published a statistical analysis plan, and we follow that to the letter, essentially. So where we had our key primary outcome measure was to look at the number of falls per person year. And we also looked at the number of fallers or faller status, so 0 versus 1 or more falls. I won't go back, I'll go forward. So what is the study flow of our study? So we had 510 people in the study, and they were nicely divided into 2 groups, intervention and control. At the bottom, you can see how many people stayed in the study. So we obviously had a dropout for reasons that people were unwell, but overall, the majority of the people were actually happy, even when they did not want to keep doing the intervention. But they were happy to stay in the study as an intention to treat, so we didn't lose that many people in that regard. So that is something that we're quite happy with. This is a descriptive characteristics of the study sample overall. So we had about 2/3 of women, which is quite common in old age and very representative of volunteers as well. But we're happy with that ratio. That's quite representative of what we see in our older population. Our mean age was 77, so we definitely had an older cohort. And dealing with technology, I hope this is encouraging news for all of you that people are very open to use technology. And iPads were still very new at the time, so there were not that many people who had one. And so overall, we had about 1/3 of the people who had a past fall. And I think overall we had quite a healthy sample for this old age group. The fallers in the total sample over the 1-year follow-up. So when we look at all falls, we had just as similar as what we always see. It typically is 1/3 of the people fell. 25% of the people had injurious falls, and then it went down to about 3% of people who had fractures. We also broke it down into different types of falls. So you can see here that the most common type was a trip or a slip. And also what was quite common was people who were falling because they were doing 2 things at once. So carrying a laundry basket or talking on the phone, things like that. Adverse events. So we didn't have many, as you can see. So these are exercise-related falls, so people falling or having an injury while they were doing the standing tall program. So this is over the first 12 months, is what I'm presenting now. We had 4 falls, and actually 2 were of the same person. So 3 people, and 2 of these falls were injurious, but a small injury, so just a bruise and some pain. The box exercises were the culprit, essentially, of these exercises, of these falls mostly, or losing their support. So we asked them to have a chair next to them, but they would just not be able to get to the chair in time. But overall, not many adverse events, so we're quite proud of that. The results now, so the first I will present is adherence. This is actually the part of the study that we aimed to address, and also the part of the study that we are most proud of. So we asked 2 hours per week over 2 years. So this is for the first 6 months that you see here. We staggered the increase of the dose just to not make it too sudden. So by 9 weeks, they reached 2 hours a week. And this is the average over the total intervention group. And you can see that most people actually reached that 2 hour per week. So this adherence is very, very encouraging. Another way to look at it is that looking at the first 6 months and the second or the total year, we had a median of 91 minutes of exercise per week over the whole sample, which is very high. And so the first 6 months we called people to make sure that they were doing their exercises, but we didn't keep doing that. So we didn't do that for the second 6 months, and you can see that it actually didn't drop that much over the second 6 months, so from 91 to 81 minutes. You can see on the right-hand side as well that we did have a dropout. We didn't quite reach our 20%, but we got close. But overall, you can see that 55% of the people did up to 100 minutes per week over the whole year. So this is very encouraging. I think you can all agree with that. Over such a large sample, that many people kept doing their exercises. When we asked about the barriers to long-term adherence, so there were our participants were very busy, and the main reason for not being able to keep up with their exercise program was because they were traveling or they were away. They had things on, essentially. They were very active people. But obviously also illness was a very common reason not being able to keep their exercises. So what is our effectiveness results? Looking at the control and the intervention group, so we can nicely see that our intervention group had less falls, so that is very encouraging to see. However, we just missed out on significance. So overall we see that there is about a 20% reduction in falls in our intervention group, but we aimed, our sample size was targeted for 30%, so we just missed out on significance, but it is going in the right direction. And bearing in mind that this was done by people by themselves at home without the need for a physiotherapist. So the progression of the exercise happened automatically. This is definitely something encouraging to know. We also had a look at the fall risk factors, and I'll go through this rather quickly because I'd just like to go to the discussion as well, and so for the sake of time. But overall, we did have a reduction, or we had an improvement in balance. So they're in the intervention group, so which is normal since the people are doing a balanced program. And something that we also see or saw and that I would like to draw some attention to, because I think it's a very important lesson, is that our intervention group did more planned exercise, which is quite to be expected because we asked them to do a planned exercise program. But what we also saw, and that's the middle graph, is that they walked less. So this is actually a very important message, because we might have replaced their planned walking or their active lifestyle with balance, and they might have thought that I've done my exercises today, I don't need to do anything else. So we need to make sure that we just give that education that it's standing tall or any other program that they do is not sufficient. They still need to have that active lifestyle. So in summary, we had a reduction in fall rates between 20 to 30%, depending on whether we looked at people who completed the program and did the high adherence, but it was not significant. We had a significant improvement in balance performance, but we also had a significant decrease in planned walks. And there were a few other fall risk factors that just did not change as well. So how do we explain our results, or how will we move forward? One question that we have to ask is if our education program changed behavior, because if we have a program that we give to people every week with nice and informative information about active living and health-related factors related to old age, we might have made a difference in the control group as well. And another thing is that we know that we need to have like moderately to highly challenging balance exercises for 2 hours a week over a minimum of 6 months to have an effect, or the effect that we aimed for in our sample size calculations. And so we definitely got the dose. So we had the adherence, we reached our 6 months. But what is something to consider is that maybe our program was not challenging enough. So these are things that we are, keeping in mind. And I already mentioned, why did we reduce our planned walking? Can we do something about that as well? Do we need to emphasize this in our education program? What did our participants think? I actually struggled to find what they didn't like. And this was a survey that they were doing on their iPad without us there, so it wasn't that they wanted to please us. But overall, people really liked the program, and they liked that it motivated them to exercise. It was enjoyable having a lot of different exercises that were tailored to them. The people who were quite fit said that they got a little bit bored. So it got to a level that it wasn't challenging enough for them. And so it became repetitive. It had a ceiling effect, essentially, for difficulty. And also what they didn't like, this was quite common, that they didn't know anyone else who was doing it because they were doing it as part of a trial. But overall, it was a very, very positive experience for everyone. And so here you can see as well, when we asked specific questions about the enjoyment and usability, their user experience, essentially, we had almost, it's about 87% really on this scale, which is considered excellent in usability and user experience for any program. So these graphs also show that the user friendliness was very high, and so they saw themselves continuing the program with comfort. Here are a few statements of people. This was also during a survey on their iPad, so where you can see that overall they felt that the program benefited them. So they integrated it into their daily life. It helped them with their balance, and it gave them more confidence as well in their daily life. So these were all very, very positive feedback. Another aspect that worked very well was the adherence. So here I've plotted a few other exercise programs using technology, and we're standing out in having about 100 minutes on average, 90 minutes on average, that people did their exercise program compared to the other studies. So there is one study, the third one, who did recommend 3 hours, but it's actually one of my own studies, so I can say it didn't work. So we only had 45 minutes that people were willing to do the program. So we definitely moved past that point by using the iPad. People were willing to use it, and they were enjoying to use it for 12 months. So this is very encouraging. So it was unsupervised, something to keep in mind. We only had 2 home visits. They were very brief. We had low attrition rates, so people were willing to put up with it, and they still are. People who came back after 24 months, most of them actually asked if they could keep it, which is very nice. The adverse events were minimal. So there were 4 falls while doing standing tall, and there were in total 37 other exercise-related falls. So I don't think there is any increased risk related to using standing tall at all. The user experience was very encouraging. There was some software malfunction that we had, but it was not a deal breaker. So people were very happy to keep going and to wait until we fixed it, but it was never very long. So the iPad was quite a reliable way of delivering the technology, the exercise program. And throughout the trial, we actually saw that technology use was increasing so rapidly. So we had done a survey before starting our intervention to see how many people had Wi-Fi at home, and we saw that there was about a quarter. And by the end of the study, when we were recruiting people, it had actually flipped around. So it was about 2/3 of the people who had internet. This is in Sydney, but this is only over a time span of 2 years. So it is increasing rapidly, and we need to embrace it, really. So what I think has happened related to the fall rates is that we might have been underpowered in the sense that our balance might not have been challenging enough. So we might have reached a ceiling effect. And another aspect to keep in mind is that we might have changed something in the behavior of everyone using our education fact sheets. So what's next? We're not giving up, so we're going to try and actually do a study that we are preventing falls, and so we have now redesigned our program. And so when we started this was very new, and we were very conservative in our progression. We did not want to increase falls when people were doing this program by themselves at home. We wanted it to be challenging, but we mostly wanted it to be safe. But now, after this experience, we know that people are able to do this program safely. And so our next version of Standing Tall is actually progressing the exercises a bit more quickly. So not too quickly, but just a little bit less conservative. We've done a few trials, and it seems to be going well, and people seem to enjoying it as well, or maybe even more than our previous version. We also have some dual task training attached to it. So for the higher levels, we are introducing a game component in it as well. So just to make it a bit more challenging and making sure that people don't keep having the same exercise all over. And we also have a grid in there, which we saw Steve present before. It is only a 4x4 grid. It's not over a walkway. So, but we have added another level of exercises in there. So hopefully we will see an effect when we do our next trial, where we will also be adding cognitive behavioral therapy to address depression. So we'll make it a multifaceted trial. We will test the education program separately because we secretly hope we have accidentally designed something quite nice. And what we will also do, and very proud of that, this week we had a training day of implementation officers, and a few of them are here today. So we are running an implementation trial now in mid-north coast New South Wales, as well as Melbourne and the UK. So where we will see if our exercise program, our standing tall exercise program, is also well received in the real world, without us calling people and being our usual annoying researchers asking whether people are doing their exercises. So we're very excited about that, and hopefully we see a nice uptake of our program. Thank you very much, and these are all the people to thank.
Thanks very much, Kim. Congratulations on such a fantastic study that I think everyone got a lot of really important information from. So here's a small gift and a certificate. Thanks. I think we have... Do we have any Slido questions? Oh, okay. Kim, would you mind just answering this question?
So what needs to have...
Oh, sorry.
Oh no, this is for everyone.
This is for everyone.
Yes,
sorry. This is my technology barrier here. Yeah. So if everyone wants to answer that question on the Slido app, and if you could, it's really interesting because I think Kim has really given us something quite innovative and some insights from you about whether this can be translated into practice. Okay, thanks very much. That's really interesting, and I know Kim was very keen to get your audience feedback, and it's a great platform to collect that information from so many of you in an efficient way. It's now my privilege to introduce you to Dr. Morag Taylor, who's an NHMRC ARC Dementia Research Development Fellow. Currently, her work is focusing on preventing disability, understanding falls risk and prevention, and improving healthcare for older people with dementia. She did her PhD on understanding falls risk in cognitively impaired older people in 2014 at UNSW, and she's presented her work around the world and has over 20 publications. She's a physiotherapist with extensive experience in aged care rehabilitation, as well as the Falls Balance and Bone Health Clinic. Her presentation today is Falls Prevention in Dementia, so join me in welcoming Morag.
People have obviously been taller than me. I'll just adjust a little. Okay, so I'm going to give a bit of an overview on falls prevention in dementia. So Keith touched on it a little bit this morning, but we'll go into a little bit more detail. So I'm going to give you background, risk factors, and then we'll talk about some falls prevention and practical strategies. So what is dementia? So nowadays it's called major neurocognitive disorder. It's an umbrella term, and it is a progressive neurodegenerative disorder affecting cognition and, as a result, people's ability to function in everyday life. So the DSM-5 criteria say that cognitive decline is complex attention, executive function, learning and memory, language, perceptual motor, and or social cognition. And the cognitive deficit shouldn't be better explained by some other illness, so things like depression and delirium that can mimic cognitive decline and so on. So as I said, dementia is an umbrella term. So Alzheimer's is probably the most common form of dementia. And then we've got vascular dementia, which is chronic brain ischemia. So this can be caused by small vessel disease, as in the picture, or it can be as a result of stroke and things like that. We've got frontotemporal dementia, which is both language and behavioural variants, and dementia with Lewy bodies. And then what's probably much more common than what has been clinically recognised is mixed dementia. And there's been studies now that show that our clinical diagnosis of dementia isn't always that accurate when we compare to post-mortem pathological type studies where people often have, particularly in older age, have mixed pathology. Okay, so this is, I'm not talking about falls here, I'm talking about dementia in general. So is prevention better than a cure? So that's a tiny picture, but I'm going to enlarge it for you. So this was a Lancet commissioned paper by Livingston, and what they showed is that there's lifespan risk for dementia, and that there are potentially modifiable risks that we can address throughout our lifespan. So if you look back in early life, you've got genetics, so ApoE4, education, and then in midlife we've got hearing loss, hypotension, and obesity, all contributing a small but significant amount. And then in later life, we've got things like smoking, depression, physical inactivity. And the World Health Organization has just put out some new guidelines for dementia prevention, and they showed that physical activity or physical inactivity has a small but significant beneficial effect on preventing dementia. And social isolation and diabetes, so some of those vascular type risk factors coming in there as well. So overall, that came to 35% potentially modifiable risk for dementia. So I guess we all work in health, and just reminding people that there are things that we can do to prevent some of these chronic type illnesses. So let's talk about dementia. So why do we care? Well, we've heard with population ageing, worldwide, we're expecting 152 million people to be living with dementia in 2050. And if we think about the Australian climate, that's going to be 1 million people in Australia by 2050 living with dementia. You can also see the prevalence of dementia increases with age, as you would expect. And people with dementia fall over, so Keith mentioned this. So this is, the numbers I've presented here are for community dwelling, and the numbers in residential care are even higher. So more than 60% of community dwelling people with dementia fall over, and in resi care that will be higher. They also have twice the number of multiple falls, so they're falling more often as well. So the consequences of falls are also more severe in people with dementia. So they're more likely to injure themselves, things like hip fractures and head injuries. They're also more likely to have poor outcomes. So they have higher morbidity, so they're less likely to regain their function, and they are more likely to die. And they're also less likely to receive rehabilitation after they've had a fall and are hospitalised. So there's a study that's shown they're 33% less likely to be offered rehabilitation. And they're also more likely to be placed in residential aged care facilities after a fall. And there's a study that's shown that after a fall, there's 28% of people with dementia have new transfer to residential aged care facilities, so a relatively high number. Why might this be? Well, we know that a hallmark feature of dementia is cognitive decline, but we've also shown that not only if we compare them to their age-sex matched peers, they have reduced physical function, but over time they decline more rapidly as well. So the graph on your left is the physiological profile assessment, and in this particular assessment, a higher score indicates poorer physical performance and higher falls risk. And you can see that the group with dementia had a significantly increase in their fall risk. This is MCI, so they slightly increased, but it didn't significantly increase with MCI. But if we compared MCI to the cognitively healthy group, they did actually significantly decline over time when they were compared to the cognitively healthy group. And this is a study just to show that potentially we've got a differential effect depending on what type of dementia you've got. So this was an 8-year longitudinal study, and this line were people who developed Alzheimer's disease, and this line is the decline in people who developed non-Alzheimer's disease dementia. So just that there may be different requirements depending on what type of dementia people are developing. So I'm going to really very briefly discuss 4 risk factors. So this is again in a similar vein to the last slide I showed you, just showing that in terms of falls risk, there may also be a differential depending on the type of dementia you have. So you can see this bottom line is the Parkinson's disease dementia, diffuse Lewy body vascular, Alzheimer's, and then this is the control group for this particular study. And in terms of 4 risk factors, we can think of them as risk factors that are unique to people with dementia, or risk factors that they have in common but are perhaps more exaggerated than people without dementia. So there's many common risk factors, so things like depression, anxiety, fear of falling, balance, reaction time, reduced walking speed, functional impairment, all of those things also increase the risk of falling in people with dementia, but they are probably more exaggerated in this population, so they are actually worse than their peers. And then we've got a couple of things that are probably a bit more unique to people with dementia, so the behavioural and psychological symptoms of dementia, so things like impulsivity and wandering have also been shown to be associated with falls. And then you've got medications, so 4 or more, centrally acting, and also total number of medications have been associated with falls in this group. And I've put environmental hazards on the end. There's actually not very good evidence for that, but just with environmental hazards, it's probably more about the way the person interacts with their environment, and so all of those other risk factors probably are more played out in the way they interact with their environment, so it's just worth always considering those other the environmental factors as well. And I just wanted to say that in terms of cognition, there's certain cognitive domains that have been associated with falls risk in this group. So executive function, which is planning, problem solving, those types of cognitive functions, processing speed and visuospatial ability. Okay, so if we move on to fall prevention, so this is the slide that Keith showed you, the study that Keith showed you this morning. And so there was a 32% reduction in the rate of falls with physical exercise in people with dementia. What I will say about this study is that it's actually a mixed population. So Pitkala, for example, is a community-based. Tanya Zishang's group, it was a mix of community, predominantly community, but also some residential aged care. The rest are predominantly residential aged care facility, but showing that exercise overall in this meta-analysis did reduce falls in people with cognitive impairment. So now I'm going to move on to looking at the different settings. And if we look at the community setting, we've got one sort of study here, which is our only really successful standalone study that's shown that you can prevent falls in people with Alzheimer's disease. This was an exercise intervention. It was intensive. So they had 3 arms. There was a control group, a home-based exercise group, and a group-based exercise group. The home and group exercise groups had 1 hour twice a week of exercise for a year delivered by a physiotherapist. In their paper, they have shown that it was cost neutral. It didn't cost more to deliver the intervention compared to their control group. But so far, it's our single standalone study that has shown that we can prevent falls in people with dementia. There are some caveats to that. The assessors weren't blind to fall outcomes. They found that they were being, the participants were letting them know whether they're actually in the intervention or not. Falls weren't the primary outcome either, and they used a modified intention to treat, so they only looked at people who came back after 3 months in terms of their falls analyses. And what I would like to say is, Keith talked about the Sutton study there this morning, so there's a couple of studies here that are underpowered. So they didn't show an effect, but they're not powered to show an effect on falls prevention, but they did report falls, so I've included them there. And there are a number of these studies that have actually shown that you can improve physical function in people with dementia, even though they may not have gone on to prevent falls. And I think that is an important message as well, is that improving people's function is important, even if we've got a bit more work to do in terms of falls prevention. And the study, the bottom study there, you can see it was aerobic and strength training. So this study, the primary outcome was cognition. So they were measuring falls, but it wasn't the primary outcome. And the type of exercise they were doing, as we've learnt this morning, is not the type of exercise you would necessarily do for falls prevention. Okay, so this is Kathy's systematic review from 2016, and the caveat to this slide is that, yes, we saw a lovely reduction in falls and using exercise in community-dwelling people with dementia, but it's a relatively small number of studies, and we've got our superstar, where have I gone? There we go. Our superstar study up here, which has got a relatively high weighting, and so that's sort of driving the results of this study. But there's potential. We've got another large randomised control trial of 309 people. The results should be coming soon. So this was a tailored home-based exercise program as well as a home hazard reduction program, and so it will be interesting to see the results from this trial. Kim's given me a nice intro to this to just say that we are thinking outside of the box for people with dementia as well. I won't go in, Kim's given a nice summary of what standing tall is, but I'll just show you, we did a small feasibility study in people with dementia, so just 15 people, and we used their caregiver to help provide supervision using the Standing Tall program. And if you look on this slide, you can see that adherence was quite variable. And we had some people who never got off the ground, but if you look at this section up here, by the end of 12 weeks, we had 5 people, which was 33% of our sample, who were doing 120 minutes of exercise a week. And I think that's pretty fantastic for this cohort. So we need to do a larger trial and look at whether we can actually show any falls prevention effect. And the other thing was we did have one adverse event, so it was that darn box again. Somebody tripped on the box, but we think probably what most likely happened is that they weren't giving an accurate rating of their performance. So just if we trial it in a falls prevention trial, we're going to need to be a little bit more mindful about how we give that education about rating their performance. Okay, so what about hospitals? So we've got our one study that was a comprehensive geriatric management post-fractured NOF, a Swedish study, which showed that they did reduce falls. And then we've got a number of studies that didn't really work. One was using an extended practice nurse for patients with confusion. Terry Haynes, they used a patient education program, and what they found was that they actually increased injurious falls in people with dementia. And so then Anne-Marie Hill went on to do an extension of that, but this time instead of educating the cognitively impaired people, they only educated the cognitively intact people, but they also provided staff training and feedback. And while they reduced falls in the cognitively impaired group, it didn't quite reach statistical significance in terms of fall rate, and they didn't do subgroup analysis when they were looking at the proportion because they looked at an interaction term, which is fancy statistical analysis to show you that they're going in the same direction, but we can't be certain that it significantly reduced the proportion of fallers either. So I've put a question mark there. It did reduce falls, but it didn't quite reach statistical significance. So maybe we're barking up the wrong tree with falls prevention, and maybe we need to focus on confusion and cognition. So this is a meta-analysis that's shown that in these non-pharmacological delirium prevention trials, that there was a significant reduction in falls. Now, I'll leave that there, but it's still a relatively small number of participants for a meta-analysis. They were predominantly medical patients, except for that Stenville paper, which I talked about earlier, which was after you've fractured your hip. And then a couple of them were not randomised controlled trials, and it also wasn't dementia specific. So I think Babine and Kaplan were the non-randomised controlled trials. Kaplan had a really high proportion of people with cognitive impairment, so more than 80%. Stenville had 30%. Martinez had 6%, and I couldn't find a report of it for the Babine paper. But maybe if we manage delirium and confusion, that's where we're going to see falls prevention in a hospital setting. So, but we probably need a bit more work specifically in cognitively impaired older people to see if that effect is true, not just for the general population, but also in that cohort. So in residential care, again, we've got this sort of mixed picture. I've put a question mark on the Jensen study there. So they had multifactorial 11-week program, and they split their sample with a mini-mental of 19. So they said if you had a mini-mental of greater than 19, you were cognitively good, and a mini-mental of less than 19, you were cognitively bad. And they prevented falls in the higher cognition group, but not in the lower cognition group. But they did prevent some fractures in the lower cognition group. But I would argue that there's probably some people in there with mild cognitive impairment that may have benefited from the program. Fiona Shaw, I've put her in the residential care, and Keith touched on that paper this morning. Their intervention was designed for community dwellers, but only 22% were actually residing in the community that took part in the study. And a part of their multifactorial program was a 3-month supervised exercise program, and then they had to continue the program independently for the rest of the 12 months. And I would say that in a residential care setting, that you might go about that differently, and we'll hear from Jenny next. Everybody keeps referring to Jenny coming. And then I've put a tick and a cross for Rosendale because they showed that if your balance got better, you prevented falls, but not overall. Killian Rapp and his group with Clemens Becker actually showed that the intervention worked better in people with dementia than it did in people without dementia. And I've put a tick and a cross for the Dutch study because they did some, in their straight-out analysis, they didn't show an effect on falls, but in their adjusted analysis for some of the differences between the settings, they did show a reduction in falls. So there's a hint that maybe multifactorial might work. So Lynn Chenoweth did a dementia care mapping and person-centred care versus person-centred care 4-month cycling sort of intervention. And they found that dementia care mapping and person-centred care worked, but person-centred care didn't and may have actually increased the number of falls, which is not what we kind of think. But if you actually read through the paper, what they found was that in the dementia care mapping group, 100% had a care plan at the start of the study, and for the person-centred care, less than 30% had a care plan. So it's probably a fidelity of the intervention problem. It would be unfair to just say that person-centred care doesn't work. And then there's a few other interventions, and again, small sample sizes for Kovacs and Clark, so they are not powered to show a reduction in falls. Van der Ven did dementia care mapping and didn't show a reduction in falls, so conflicting to the Chenoweth paper. And then Julie Whitney in the UK just did a pilot cluster randomised control trial and unfortunately didn't reduce falls. So from the Cochrane review, which Keith also touched on, but they actually looked specifically in the cognitively impaired subgroup, and there was no clear benefit on the rate or the risk of falls in the 4 studies for each meta-analyses that looked at the subgroup analysis there. So I would say that they had it was going in the right direction, but it didn't reach statistical significance, and because the confidence interval crosses 1, and particularly for the rate of falls is much higher than 1, we can't be 95% certain that the intervention worked for people. And there was a non-significant 21% reduction in the risk of falls. So we all keep referring to Jenny, as I said, so she's coming up next. But all I wanted to say that when you listen to Jenny, that in her cohort, about 50% had dementia or cognitive impairment. So just keep that in mind. And the Addenbrooke's Cognitive Examination Revised, the cut points that have been used for dementia with relatively high sensitivity and specificity is 82. So you can see that the cohort, but I'll let her tell you a bit more about that. So practical strategies. So if we're seeing people, we've got all of this kind of mixed evidence and we're not really sure what we're going to do. So I guess there's some key messages that when you're treating people that I would like you to take away and think about. And that is to identify, assess and consider cognitive impairment in the way you manage and treat people. So Keith touched on this in that we need to tailor our interventions to people. And there's different types of cognitive assessments that can be done. There's short screening tools, which is better than nothing. And then there's longer screening, which can give you sort of domain impairments and those sorts of things, looking at processing speed and executive function and those sorts of things. And it might just change, the way, whether you decide somebody is compliant with their call bell or non-compliant with their call bell. If somebody cannot remember to use their call bell, they're not being non-compliant, they just can't remember to use it. So we need to come up with other strategies to manage that. Prevent, recognise and treat delirium. So this is the delirium clinical care standard, and the typing is very small, so I've made it a bit larger and simplified it a little. So if someone's at risk of delirium, screen on admission. Screen for cognitive impairment on admission. If there's an acute change in someone's behaviour or cognitive function, assess for delirium. If they're at risk of delirium, make sure that we've got delirium prevention strategies, which are often the same as the strategies we use to treat delirium, but make sure that they're in place. If they have delirium, come up with a comprehensive intervention to treat the causes. And if they have delirium, consider falls and pressure risk in terms of the interventions we come up with. Non-pharmacological management is always best, and pharmacological management should be used as a last resort. So we should try everything else first. And when people leave hospital, they should be given information about delirium and they should have a care plan that's developed with them and their caregiver. And then this should be communicated to the appropriate people. So Anthea's here somewhere. So CHOPS, which is care of confused hospitalised older person. And this covers many of the same principles that I showed you in the last slide, but it's a fantastic resource that has excellent education on it, so it's worth checking out. It's all online, it's all free, there's videos and all sorts of things, so it's just worth having a look at. Person-centred care. So we need to put the individual at the centre of their care and think about them. Their goals are as important as our goals. Think about what they like and dislike, their past lived experiences and cultural background, precipitants to behaviour, and specific behaviours are often a result of unmet needs, so thirst, hunger, needing the toilet, cold, hot, those simple things that, is there water within reach? Those simple things that can help keep people more comfortable, and that everybody should be treated with respect, dignity and compassion. I just got this off the Commission, the Australian Commission on Safety and Quality in Healthcare, and I thought it was a really nice summary of putting the person at the centre of care. And I'm not going to go through all of it, but the first thing that caught my eye when I was like, yes, and that's the patient, that they feel heard. I think in healthcare we often are busy talking to people that we sometimes forget that we need to listen to what they need to tell us as well. Care engagement. So carers are our friend and we need to work in partnership and acknowledge their expertise because they know the person best. They're a source of information. So the top 5 is just one strategy to help caring for people with dementia or cognitive impairment. So you talk to the carer, you get information from them, you personalise the person's care, and you come up with 5 strategies that you can use to help you care for that person. And everything's available online for top 5 as well. Let them communicate about the person for dementia's needs and also come up with a collaborative type plan. We should also consider the impact of the intervention on the carer. And also for clinicians, trying to give them some practical examples of if there's ways that we can help them manage behaviours better and things like that. The other thing I think is important is that we focus a little on the person's strengths and not just focus on everything they can't do, because there are still things they can do. And if there is a task, so say going to the toilet or showering, there may be many components of that task that they can actually keep doing themselves. They might just need it facilitated a little. So somebody might be able to dress themselves if the clothes are laid out in the order they need to put them on, for example, versus just coming in and taking over the whole task. And that way the person keeps active and you're engaging them in their own personal care and daily life and so on. Communications, I touched on this a little, but respect, empathy and listen. Consider your body language and tone, and also your body position. So you want to make sure that you get sit down if you can, so that you can be at eye level. Speak slowly, clearly, and try not to use our medical jargon. And obviously you need to tailor this to the individual, because it depends on what level of cognitive impairment they have. But some people might need short sentences and instructions broken down. You need to allow time for the person to process what's been said, but then you also need to allow them time to respond. So they need to be able to process it and then come up with a response, so allowing time in a communication. Clarify the meaning of what they say, but also clarify their understanding of what you've said. And remember that that might change over time depending on what cognitive impairments they have. Minimise competing noise, use hearing and vision aids, and use personal references where you can. And just to say that on the Falls Network website, there's Professor Anne-Marie Hill gave a fantastic talk on communication in healthcare, and some really nice sort of pieces of information about how patients perceive themselves in hospital. So I'm a physio, so I've got to talk about exercise. Just some practical considerations. So I think paramount is supervision and safety. So we need to try and make sure that people are safe. Again, focus on their strengths. It needs to be tailored and progressive. Consider their comorbid conditions, how you're going to communicate and instruct. Make it achievable, sustainable and enjoyable. And as Keith said, that we probably need to be a bit more flexible about the way we deliver exercise programs, and not just I'm going to give you these exercises to do, but how we can incorporate it a little more. So in summary, older people with dementia are at increased risk of falls and fall-related injury. There's been a number of modifiable risk factors that have been identified. Exercise potentially prevents falls in community-dwelling older people with dementia, but we probably need some good quality trials to repeat those findings. In the hospital, it's a complex care environment, maybe multifactorial, and it might be that we need to look at, so hospital and resi care are a little bit similar, it might that we need to look at those successful trials and really try and learn what it was about those successful trials, and then try and use that information for future trials. Vitamin D, so I think Steve touched on that this morning, vitamin D for those who are deficient, and people with cognitive impairment have often been included in those trials, those large trials in residential care. Many other positive effects of exercise, and kind of we need more evidence in this cohort, but until then, just strive for high quality, person-centred, comprehensive care. Thanks. There's a bunch of resources.
Thanks, Thanks very much, Morag, for going through some really complex research data and leaving us with such a great amount of practical advice and interpretation of how that really can be used in the clinical setting. So I'd like to present you with a certificate and a gift. And now we have to have a picture, but congratulations. Thank you. Thank you. Okay, and if everyone wants to get their phones out and have a look at the question that we've got, what would help you feel more confident in managing fall risk in people with dementia? So you've got some time to put your responses in, which we'll eagerly await. 4 people already in, 5. We'll let those responses come through. So this is the first of 2 questions, so we're just going to look for a few more responses coming in and then we'll give you another. Okay, we might just move on to the next question without looking at our results right away, just to get those responses in. Oh, okay, sorry. We're going to move along to Jenny's talk. We're just running a little bit short on time. So this has been very eagerly awaited and we've had many references. So I'm delighted to be able to introduce Dr. Jenny Hewitt for the last speaker in this session. Jenny is the Clinical Education Coordinator for the Centre for Rural Health in Murwillumbah. She's a physiotherapist and researcher with a passion for enabling older people. She conducted an RCT on strength and balance exercise in residential care with the University of Sydney UTS and the University of Queensland. Having previously worked in the sporting sector, Jenny has a keen interest in best practice exercise for falls prevention and quality of life for the oldest old. She was recently awarded the Australian National Lifetime Achievement Award for services to aged care, a National Commendation Award for the Aged Care Quality Agency, and the 2019 Morley Award for the paper most likely to influence policy and practice from the Journal of the American Medical Directors Association. So I really look forward to hearing Jenny's presentation, which is Exercise for Falls Prevention in Residential Aged Care, Evidence of Clinical and Cost-Effective Outcomes from the Sunbeam trial. Welcome, Jenny.
Good afternoon, everybody, and thank you very much to the organising committee for inviting me to be here. I'm very excited to talk to you today about the Sunbeam trial, which started in 2012 as a result of a physiotherapist working under ACFI, the Aged Care Funding Instrument, who was feeling disillusioned and in need of, let me just get this working, and feeling that the system needed to change. Why am I not getting that to go? Oh, there we are. Okay. I won't talk too much about this. I realise we're a little behind and there has been a lot of information given in the lead up to this talk, but we know that residential aged care, people fall a lot more often than in community. We know that falls are the leading cause of preventable deaths in this setting, and that most recently we're looking at between 60 and 63% of residents falling, which is almost double what we're saying about for the numbers in community dwellers. We know that there's going to be a lot more people living in residential aged care towards 2050. I'll probably be one of them. This morning we heard from Natasha that no other single injury costs more than falls to the health economy. So why do people fall? Well, as a physiotherapist, I was particularly interested in the two blue tiles here, but we know that people fall for a variety of reasons, and we can't necessarily impact on all of those. Whenever I have a resident fall in one of my villages, I go along to chat to them about what happened and to try and find out whether there's something that we could do to remediate. We can't address everything. I'll tell a quick story. My favourite falls story, if there's such a thing. It was a 98-year-old resident, because I come from far northern New South Wales, not too far from Nimbin, and you can probably see where this is heading. So I said to her, I'll change the names, of course. I said to her, "So Mavis, tell me about the fall." She had a couple of fractured ribs, and she said, "Well, Jen, you know how I've been having trouble sleeping?" And I said, "Yes." And she said, "Well, Betty and I," so Betty's her 78-year-old daughter, "decided we'd try marijuana." And so Betty went to Nimbin and picked up some quality leaves. That's actually what she said. And I'm really opposed to smoking, so we squashed them up and popped them into a capsule. Anyway, we downed them in Betty's garden, and not long after I popped up off my wheelie walker and I took 7 backward steps and I fell into the bird bath. So I still got my pen poised over the incident form, and I said, "Okay, so exactly which part of that should I record on the form?" And she said, "How about just the part where I fell into the bird bath?" Anyway, moving on. We have spoken about the Cochrane reviews already earlier today, and we know that there's very clear evidence that exercise is beneficial for falls prevention in that setting. Keep in mind that when I was looking at doing this work, it was around 2011, and so the data that I'm presenting here was pertaining to that period, because that's when we were trying to set up what we were going to research in particular. But there hasn't been a lot of change even in the most recent Cochrane review, as we've already heard about the evidence so far for exercise in residential aged care. But I did want to have a look more closely at the 2010 Cochrane review, because that was the most recent one at the time, and have a look at the studies. You can see that there's only a few studies. You can see, as we've spoken about a few times earlier, that we don't really know whether it helps because the diamond sits right on the line. But what I wanted to do at the same time, Kathy Sherrington and Ann Tiedemann produced a paper around 2011 that broke down the components of effective exercise programs, the key components. And we've spoken about this at length already this morning. We know it had to be 50 hours, higher level balance work, strength work if people are deconditioned, individually upgraded and progressed, closely supervised. And so then what I wanted to do was go back to the previous slide and have a look at those studies and see whether anybody had done that. Because we've spoken about the integrity of the research design a little bit today, but what did they actually do? And when you've only got that many studies, you have to lump them all together and call it exercise. But we all know, those of us working in the industry, and just it makes sense that not all exercise, you're not comparing apples and apples, not all exercise is the same. So I had a little look at those studies, and this is what comes up here. But these are the studies that did show a reduction in fall rates. You can see they're quite small numbers, quite different in terms of how long they followed people up for. One of them had 100 hours on one of those treadmills that Stephen spoke about earlier. Another one had 6 hours of exercise, which was computer balance training. I don't think that's what they meant, but I couldn't resist that picture. These 2 studies are sort of orange if you think traffic lights, so they didn't show any change. Not that they showed a reduction or an increase in falls, just no change. That was Tai Chi versus single leg standing. Rather similar dosages there. Now these studies all showed an increase in the fall rates, and this is where things became problematic for those of us working in the industry who are trying to say we should be exercising people in resi care, because all of these studies showed an increase in fall rates. But when we look at them, they all included walking. And we know that was in 2010 that this was published, and we knew in 2011 that exercise programs that included walking as part of their components resulted in an increase in falls. So we're thinking here, and Kathy Sherrington and Anne Tiedemann certainly said this in their paper, you can't consider walking to be a falls prevention strategy. So what I decided then was that if we're thinking of exercise as medicine, really type of exercise, dosage of exercise and frequency of exercise matters. We can't just call it all exercise and think it's the same from one trial to the next. For example, if you were talking about medicine as medicine, would you give someone paracetamol and expect that their blood sugar levels were better? Well, I was thinking in the same way, would you give somebody some kind of exercise and assume that all kinds of exercise will affect falls? So that's where I came from with the background. So we looked back at these components that I just spoke about a minute ago, and we decided then to conduct a trial which implemented the key components of best practice at that time, which was 2012 by then. So we made sure that the program was conducted across a number of centres. It was a cluster randomised control trial, meaning that we randomised the whole village rather than randomising individuals, because you can imagine if you bring an exercise program that the residents talk about is a lot of fun or that they're enjoying, and the person beside them at the lunch table was randomised to receive no exercise, it starts to get tricky. So we brought the villagers in pairs, and one got the gym and the other did not, and then we kept going until we had recruited 16 clusters or 16 aged care villages and 221 participants. I'd just like to acknowledge an amazing group of supervisors. That Catherine Refshorg is a physiotherapist, Stephen Goodall is a health economist, Lindy Clemson is an occupational therapist, and Tim Henwood is an exercise physiologist. So we had a very broad range of multidisciplinary input there. It was called the Sunbeam program. That's a photo from my driveway up in far northern New South Wales. It was called the Sunbeam program because I put the word strength and balance exercise in aged care into Acronym Finder, and it came up with a number of different versions, and some of them were hilariously R-rated that I won't share with you. But we put this one in, and that's what the residents voted for, so that's how it stuck. So that's a rather busy slide, but the things that are important to look at, the mean age was 86-ish in both groups. There were a lot more females than males, which is a common thread we've heard today. People were in aged care for quite a long time, right around about 2 years-ish. There was a lot of high care categorised residents. When you look at the falls, you can see that in the prior 12 months, the intervention group did accidentally have a lot more falls and a lot more fallers in it, but when we performed some statistical analysis, they were not significant differences. However, they might have been clinically relevant, and certainly if you were a betting person, you'd have bet against the exercise group based on the previous falls. There was a whole range of other comorbid conditions, of course, and not many of them were on vitamin D. So if we come to look at the program itself, we can see here that we used progressive resistance training in a group setting. There was up to 10 people in each group. Each of these pieces of equipment, do you like the exercise shoes, the wetsuit booties? So you can see here we put a smart card in, it pops up with the person's name. It's individually prescribed exercise, weights, sets, repetitions, and while they're sitting down doing their strength, I can do these complicated high challenge balance exercises. So they're getting a combination of resistance and high level balance training. This part of this slide makes me laugh because as soon as the cameras rocked up, a couple of participants attended that had never ever come to exercise before. But the oldest person there is 101. This is static balance with your eyes closed. And then we did other exercises such as imagining that you're on a boat, reaching over to pick up your champagne. Rocking from side to side. At Christmas time we actually had champagne. This is a reactive stepping task, falling, falling, catch. Falling, falling, catch. So they either have one hand, two hands or no hands on the table. Watch the lady in the yellow, falling, falling, catch. See, high challenge balance is not for the faint-hearted in this setting, I can tell you. This has some sound on it, Mark, if you're listening. So this is how you run it in a group-style circuit. Oh, it's a bit loud. Don't you love them? I think one of the reasons this was successful is that strength work could be really done with almost no supervision because everything was individually prescribed, and that left myself and one other person to be able to do this sort of really high challenge balance work, one-on-one and in a group setting. So this is the grapevine. You say, you want me to do what? This fellow might not start, just one moment. You wait and see what happens here. Down, down, up, up, down, down, up. As you can see, we had a lot of fun doing all this. Oh, hang on, I've got to get on to the next slide. So what happened in the end? So this is a table from the JAMDA publication. After 6 months, they did 6 months of that type of training, and then the gymnasium and I moved on to the next village, and a maintenance program continued, which was conducted 2 half-hour sessions per week by usually the activities staff, the recreation staff, or sometimes some trained volunteers. We then measured the falls rate, the number of falls and the number of fallers, as well as some other secondary outcome measures at 12 months. So you can see there that the falls rate after 12 months was 1.3 in the exercise group and 2.9 in the usual care group. The total number of falls, 142 versus 277. We weren't powered to look at multiple fallers and so on, but you can see that people that fell more than 5 times was 9 versus 20. Injurious falls was about half as well. The fall-related fractures was not really any different. That is probably a separate study with a lot more people in it to be able to look at that. This is how it looks graphically. So 0.4, the incident rate ratio, 4.45 means a 55% reduction in falls. So let's get some words on what they thought. The people that are talking in this section are all in their 90s, visually impaired with polypharmacy, but they were cognitively intact when they spoke to us.
A world of difference. I can walk taller. I'm just so much more able to get about. It's wonderful. As I said, I was a couch potato and I didn't move, and just one day was like the other. Now I look forward to the exercises very much.
And I got out of the car and went to step up the step and tripped on something and went forward violently so that I was parallel with the ground. And I kept on moving and forced myself upwards, and I eventually prevented the fall. I was able to straighten myself up. Yes, I would have fallen flat on my face if I hadn't had those exercises.
Leg-wise, strengthening your legs, to be able to push up from the floor without your hands and get down into your chair and up easily. And just generally overall, they strengthen the body.
I can just move with my family a little bit more. They don't quite have to wait on me quite so much.
Actually fell where I aimed for, really, on the floor, and dodged everything. And it was a good result, and that came from these classes.
There's only one way to go now. That's up.
It's incredibly tempting to cut that bit out about fell where I aim for, but let's be honest, you still fall sometimes. So with that information, as I said, it was the reason I was keen to do the study in the first place was so disillusioned that physio and now EP as well. Allied Health is only funded to do TENS and massage or similar type passive treatments in residential care. So once we had that result, it was time to try and lobby for change. And so the information was taken by the Australian Physiotherapy Association as part of their dealings with the federal government on the ACFI reform, which is currently underway. So part of that, even though we all get warm and fuzzy looking at changes in fall rates, the policymakers really want to see whether it's cost effective. So I won't go into that nasty looking table too much, but what we did was basically spent time going through what it costs the villages to have a fall, and then we looked at what it costs for the ambulance, how many ambulance attendances there were, how many people were taken to the emergency department and the costs associated with that, how many people were admitted, and so on. The way that we speak about cost effectiveness in health economic terms is ICEs, or incremental cost effectiveness ratios. So it looks at the cost of the intervention, because clearly there is a cost when you have a gym and personnel, over the cost of usual care, which was nothing, over the effect of the intervention and the effect of usual care. So in this study, it cost $22 to avoid each fall, which is peanuts really. If we have a bit of fun with all of that, have a look at if every Australian residential aged care village in the whole country implemented the program. At the time I did this with the health economist, Stephen Goodall. There's about 172,000 people in residential care at the time we conducted this 2 years ago. Only 25% of people in the villages picked up and said that they'd do it, so it's not a huge uptake, which we've spoken about a little bit earlier in the day. Under current care, with the falls rate we had in our study, that's how many falls you'd expect. The cost of a fall is about, in this study, was $400 per person, so that costs about $50 million. The Sunbeam program, you can see there's a lot less falls, applying the same cost, is a $27 million saving just in that, in the acute costs of falls. Terry Haynes a few years ago did a study looking at acute and long-term costs, because, you know, if somebody has a fall, it's not just the acute costs that incurred on the day. If they then go on to need to have, for example, from being independent to having one to assist for the rest of their days in the village, or two to assist, and then those long-term costs are incurred. They modelled that it costs $1,750 a fall in residential aged care. So applying those same rules leads to an estimated $120 million in savings. Those savings, though, are spread between the federal government, because they don't have to pay as much through ACFI, the state government, because they don't have to pay so much in ambulance and hospitals, and the residential aged care villages themselves, because they don't have to pay for as many staff to look after a person after a fall. So getting somebody to look at that, any of those three, to look at that figure and they go, okay, well, we're going to pay for the gyms, etc., is the tricky part. So what do we do with all of this? So we've published the RCT, we've published the cost effectiveness paper, we're sharing the findings responsible for those, with those responsible for reform. So that top picture on your right, that was me presenting to Minister Wyatt, who thankfully was re-elected and then unthankfully changed portfolios last week. However, we'll just go and see the new one. And then we had a bit of a story on the ABC News. I was invited by JAMDA to go and present abroad as well. There is this new thing called the RACFI, Revised Aged Care Funding instrument. It's a summary report that came out just as my results were being reviewed for publication, so we were able to share the document with them, and this is their take on it. They've decided that. So these are the people who are making the changes to ACFI. For those of you who work in residential aged care, I can feel your heart singing, because they're finally saying exercise is a useful therapy. So they're going to try and put therapeutic exercise into the pain management fix, because otherwise it's too... But what that means is we should now be able to be providing exercise 4 times a week if they've got a 4B. And that's me doing cartwheel when I read the paper. Thank you. So to translate that to practice, what does it look like? It looks very similar, of course, to what Kathy and Anne put out, except that in our study, people didn't need to exercise 50 hours a week. People didn't tend to exercise that often. That's 2 hours a week for the whole time. People get sick, people go off the boil, just get tired, can't be bothered, whatever. But if you exercised even 60% of that, so 30 hours or more in the 6-month period, you still got the 55% reduction in fall. So the dosage is a little different. So if at 1.2 hours is about 72 minutes, give or take, so if you're going to be seeing somebody, you can run 3 half-hour sessions, and that gives you 90, Monday, Wednesday, Friday exercise classes. You can do it within the 20-minute allocated for 4Bs, and you will still get enough exercise. So the exercise, so now we've got the other thing we've got to think about is what to do if you don't have a gym. So we haven't studied this, but so I'm just going to finish on how I've been trying to figure out some implementation work. These are the exercise groups we included. So if you haven't got a gym, I supervise students and they've been fabulous because they have to do outcome measures projects. And so we've been trying all manner of different ways of implementing individualised resistance training without a gym. We're going to cover that this afternoon in our workshop. So you can still do abduction and adduction with TheraBands. You can do leg press, you can do triceps, you can do all of the exercises that we used using bands, resistance bands. That cheeky man told me I better be careful because he married his last dance teacher. In terms of the high balance exercise, this is what was included in the trial, and they were certainly not requiring any machines. But balance exercise gets a bit dull after a while, so we've been trying to do a bit of balance with flair, we call it. This fellow was the fellow at the top with the boxing mitts, used to box from his wheelchair. Now he stands in the parallel bars and boxes, although you can't really catch the parallel bars when you've got boxing mitts on. We also have a Nerf gun with a target. They're a bit small, but so down on the bottom left, you can see it's quite easy to get ladies in their 80s up dancing with 20-something-year-old male physio students. And the 2 pictures up the top with the black around them, we bought a football table. That was good fun. Got the men's shed to put that together. You can see the man has stood up out of his electric scooter to assemble it. And that other contraption that was in our men's group, a secret men's business. Some of you might be able to tell me, but I understand it's a beer pong. So I'm hoping that from today you can see that there is evidence if you implement the right type of exercise, the dosage, you can affect falls in residential aged care, and now the challenge is to roll it out with or without a gymnasium. Thanks for listening.
Thanks very much, Jetty, and I think you'll all agree that that was both entertaining and scientifically incredibly impressive, and also so exciting to see the research getting translated into real practice change. So congratulations, and here is your certificate. And a gift. There you go. Thank you. Just that picture. Thank you. So we've got our Slido poll.
Is this working? Yeah. So we're just going to double up our multitasking here. Can I get Maura and Kim as well? So I've picked 3 of the most common and repeated questions that have come in through Slido. Morag, can you recommend a short or the best screening tool that we should be using to measure the level of dementia?
How short's short?
I guess I'd ask how short's short. The mocker is relatively quick and covers, I guess, the mini-mental, which has traditionally been used, doesn't really very effectively measure executive function. So the mocker, I think, does that a little bit better. There are much shorter screening tools like the AMTS that is used, I know, in the emergency setting. The trick, I think, is trying to come up with something that does measure executive function. And so the other thing you can do is put 2 short tests together, for example. So you could do something like the AMTS and then get them to draw a clock and ask them to set the time at 5:10. And there's different scoring systems for the clock, but that's can give you a relatively quick indication of their sort of visuospatial and executive function. So if you're going to use a sort of shorter screening tool, then that might be your option. But if you're looking for a sort of a one-stop shop, relatively short, then the mocker is quite good.
Thank you. Another one that came up very frequently, this is for Kim, is the mat available and where can we get the app from?
Well, interestingly, the mat is the one thing that people gave back when they wanted to keep doing the exercises. So our next program actually doesn't use the mat, so we are presenting it on the screen. But we made it ourselves, so we designed it and we had them made, so they're not really for purchase. But if there is anyone who wants one, we still have some left over, so maybe we can organise something. And the app, yes, quite important. It's not available for purchase yet. So we are at the moment running a clinical trial here in Sydney, and we will do the implementation trial in northern New South Wales and North Coast, Melbourne, the UK. There is also a site in Tassie. So if there is anyone in the community living in those areas, we might be able to give it to them if they fit our inclusion criteria, but it won't be available on the public app store for another 3 years probably, and after that it will be launched fully.
And the last question for Jenny, how would you account for participants doing other exercises besides what you have recommended that they're doing in the gym? This goes both for the intervention and the control group.
It's standard practice in residential aged care that there's some kind of exercise program running. Usually that's done, at that time, it was usually done by the activities staff. It was very rare for it to be run by the physiotherapists. There has been a bit of a change in that because a lot of providers now use the 4B funding, which means that the physio visits 4 days a week. They often use that to do exercise. That was one of the selection criteria for the aged care village. So if that was happening, then we weren't able to include them in the study because that was going to mean that if that village was randomised to be the usual care group, they'd also be getting the same amount of exercise. So the recruitment happened between 2012 and 2014, and that we just excluded villages that used that approach at the time. So usual care just meant they were mainly doing seated exercises or some standing exercises with a DVD or something like that, and those programs continued in the intervention villages as well. We didn't ask them to stop anything that they were doing.
Great. We'll just stop there for the questions. As you've seen, I've collected many, and we will come to those in the panel discussion.
So join me in thanking the presenters in the session.